So thanks everybody for being here. It's my pleasure to be talking about something that we have been working on for about 4 years. Everything started when I started talking to Dale and Will about how to extrapolate things that we're doing in like bringing engineering fluid dynamics into the cardiovascular system and how to better use this into the urological world. And it got further developed, or has gotten further developed, in my collaborations with Dr. Wade Bushman and Shane Wells. And I'm going to be presenting today some of the advances that we have had with this. So first of all, I mean, you guys probably know and have seen this plenty more times than I have. But just to give a brief background of what brought us to this world is we were looking into how the enlargement of the prostate would affect the fluid dynamics of the urinary system. And I mean, obviously, there has been different angles in which we have tried to look at this, which are, for example, with Dr. Diego Hernando, who is an imager in medical physics and radiology, we were looking at how to better characterize the stiffness of the prostate when it is enlarged. How does that affect the symptoms? In my own interest, I was looking at how does the perfusion change in the bladder wall, or different ideas on how fluid dynamics could be applied to this. So some of the things that we have looked at is like, how can we complement what clinicians can use in order to diagnose or treat lower urinary tract symptoms, either they're due to benign prostatic hyperplasia or any other condition. And we've been focusing lately a little bit more on how the bladder biomechanics can be characterized. So current urodynamic studies are invasive and provide relatively limited information about the performance of the bladder, and hence like they are limited in how much they can be diagnostic tools or serve as a surgical planning tools. So our aim here is to develop or to implement an MRI protocol for studying bladder biomechanics. That includes using already developed and implemented MRI techniques from like other territories in the body, like brain, heart, any other territories, or working towards developing this technology. Let's see. So one of the first things that we started doing with this was, okay, how can we use anatomical data from MRI to be able to identify markers of changes in patients with BPH, for example. So here is just a brief summary of what we did in a retrospective study with different ages of patients. And we were looking at how the bladder thickens with age and which regions of the bladder would thicken with age. And this was trying to implement how just segmentation of the images would give us powerful information about this. And I'm not gonna spend a lot of time here because I'm gonna dedicate more time towards the dynamic part of this. But this is how everything started. How does the bladder wall thickness change with age or with different conditions? Then we started looking at, okay, how can we do real-time imaging to be able to capture the voiding in the scanner? With this, we've gotten into a lot of different feedback from different angles, which is like, can patients void in the scanner? How can we get the voiding cycle to be timed in a way that we don't lose information as we go? So we have been able to scan about 10 patients, out of which 70% of them have been able to urinate in the scanner, which has been kind of a successful story so far. We've been trying to figure out how to make it easier for subjects to do it and how to be able to get more information. Our protocol for the dynamic analysis is pretty simple. It would include anatomical data, then we would do the dynamic imaging, and then we would do anatomical data at the end. And this is how we have worked so far. However, in collaboration, again, with my colleagues in medical physics, we have been extrapolating things from two-dimensional acquisitions to three-dimensional acquisitions, and that's the focus of my talk today and how I'm gonna show it. So in brief description, what we do with this information, or what we have done so far, is, okay, we can get the change in area if we do it two-dimensionally, as you can see in the left lower panels, and we can see how the bladder deforms. However, this is only a sagittal plane that gets prescribed before the void. And so it could be subject to motion. It could be subject to other things that make us miss, for example, what happens at the bladder neck or some other areas. So what we do with this is we track, as you can see with these green lines, how the bladder deforms, and we can impose that into a computational model that interpolates between the initial volume and the final volume to get all the voiding dynamics. With that information, we can determine how does the bladder void the urine. And this on its own was kind of a great tool that we could bring from the cardiovascular world. However, there has been some findings in our own studies that show that the symmetry that we display here is not necessarily true for every subject. So it would be great to have a three-dimensional acquisition that allows us to characterize regional asynchrony or regional discoordination of the motion of the bladder wall. So here, for example, is something that we found when analyzing healthy subject in a BPH patient, in which we see that the dome just moves much more than other regions in these simulations that we perform based on the patient-specific data compared to the BPH patients, which makes sense. I mean, the BPH patients showed much higher post-void residual, which means, I mean, they were not able to void as much. So in order to further our analysis into this, we decided, okay, now that we have the three-dimensional information, even though it's kind of an interpolation between 2 points based on only one sagittal plane, we were able to say, okay, how can we get these models to tell us more information and specifically show us more detailed results? And the main idea with this, and I forgot to mention, is if we were to be able to regionalize the perfusion of a bladder, we could understand, can some regions be hypodynamic or hypokinetic due to lack of perfusion, which is something that is done in myocardial infarction in patients that have had like a heart attack. So in this case, what we've done is we've separated the walls in left, right, posterior, anterior, and then dome and base of the bladder. And here, I mean, these are too small, and I wouldn't spend too much time looking at these graphs. But what this shows is how asymmetric is the contraction, especially in the patients with prostatic hyperplasia compared to the healthy. As you can see here, this yellow dome means that they totally move downwards as the bladder was voiding compared to the other subjects. For example, this third patient had a better performance. However, it took forever not forever, but like 3 minutes to void. So those are some of the risks that we run into if we prescribe a scanning time of the real-time sequence that is only 2 minutes. Then we might miss a lot of information at the end of that. So that's a learning curve, and that's something that we're working on to try to better implement these methods. So with all this and coupling the numerical methods to the imaging, we can come up with some different metrics like the displacement probability function that allows us to understand what's the probability of each of the elements in the wall to go concentrically down to the isocenter of the part. This is a little bit more engineering than we need to see, but at least it shows us that the controls are all lumped in one area, whereas the patients, they have higher asymmetry than what we have with the controls. And this is all based on the simulations that we have performed. So with this, we can not only see what happens to the bladder wall, which is something that we like to see, but also see what's inside of the voiding period, right? How does the velocity get to play a role? How can we calculate pressure drops across the urethra in different regions? And all this is accomplished with the same type of simulations that we're looking at. And that, I mean, this is just an example of how the velocity distribution happens and how we can see later how the vortices form in the different models, right? So vorticity within the bladder, we don't know at this point what that could mean, but being able to quantify it and seeing that it might be a waste of energy, it might be that the resistance in the prostatic urethra is just increasing the residence time of the urine inside of the bladder, that might connect with something else that is shown in the clinic, right? So our main goal is to be able to bring all these tools to a point in which they become something complementary to everything that is done by the urologist when looking at the patient and seeing how this could help more. And that's something that we have tried to do here, is like, how do this streamlines show us more information than what we can already get based on the motion, and what markers or what metrics, quantitative metrics from MRI, can bring more information into the picture and make it more translational. So that's what we do, again, with like vorticity metrics and how that performs, for example, in patients having less vorticity. What would that mean, and how could we correlate this? And that's why we're looking to do more studies in which we correlate our findings from non-invasive urodynamics, or MRI urodynamics, as we have been calling it, to the multi-channel urodynamics. And in fact, working with Dr. Bushman, we looked at some patients, I mean, those 3 patients, and we were able to, I mean, using data from one patient to normalize what we obtained from the numerical simulations. We were surprised, and I mean, obviously it's an N of 3, but we would keep doing this. We were surprised in how good of an agreement we obtained in terms of how does the BCI calculated based on MRI compared to that calculated from multi-channel urodynamics. So the idea here is we're not trying to go and like take over the market of urodynamics by any means, but we would like to make this a tool that could improve both the diagnosis and both the surgical planning, also improving the quality of life of the patient by doing something that is totally non-invasive. So these numbers are pretty encouraging, and that kind of led to being able to improve our protocols and get data from more sophisticated techniques. And so with that, we started to work with 3-dimensional real-time imaging, which is something that I was mentioning at the beginning that has me really excited. Here on the left, you can see the bladder, the total volume of the bladder, totally full. I mean, you can see that the urethra is not visible there. Obviously, this red one is just eye candy. I mean, I just wanted to put it there because I love it. I think is a great 3-dimensional model. But here you still don't see the urethra. You just see the volume of the bladder in sagittal planes. And again, this is almost isotropic, so we can reslice this in any direction. You don't see the urethra here, but this is the total voiding period in the sagittal plane, right? And then here we would have one thing that I want to show is this allows us not only to see the voiding cycle, but where does it push? Where is the bladder wall moving? And the reason why I wanted to do the previous video, and that's why I'm going to return it, is we get, for every time frame, we get one volume like this one. So it's not just one sagittal plane and this, we have volumes at every time frame. So with that, we can reslice and then be able to see, for example, the urethra during the whole voiding cycle, right? So that allows us not only to get mechanical properties or pseudo-mechanical properties of the wall or dynamic properties of the wall, but we have the idea of using this displacement of or increase and decrease of diameter of the urethra to calculate the stiffness of the urethra, for example, or other mechanical properties that would that could be derived from these parameters. So based on this, we can quantify different things. And again, I keep bringing this views because sometimes it's hard to be able to display this in a nice way. But as you can see here, we have a volume that is kind of an intermediate volume that is a video of, like, I don't know, probably in the middle of the voiding cycle because the whole urethra can be seen. And then here we have a volume that is at the end, right? So I just want to make sure that it's clear that we have volumes at every single time period of the voiding cycle. And this is what we get to do. And this data was acquired last week. I'm glad that my students are. So one of the things is to get students that work harder than you, and then in that way you can be able to display the results quick. these are the segmentations of the different time frames that we were talking about. And this allows us to see how is that moving with respect to what we call the isocenter, right? Or the center of mass of the bladder. So we can get all this and calculate different metrics and come up with different ideas of how to get. So for example, urinary flow, the way I look at it is you have the initial volume, and then as the volume goes down, then you get to different markers. What is the voiding fraction? Well, you have the initial volume, you have final volume, and then you get the voiding fraction as you do with the cardiac output or stroke volume or ejection fraction in the heart. What is the post-void residual? So we can get those calculations pretty easily by getting all these numbers. So when I first showed one of these figures to Dr. Bushman when we were discussing this case, he said, well, this is an engineering way of looking at that. And sure enough, I wanted to match urodynamics. I need to start looking at this as the urologists or people doing urodynamics would do it. So if we convert that curve, that gives us voiding rate, right? So how is this process happening? When is the maximum voiding, and how much time does it take to just kind of slow down and do it? So this is the curve that would be analogous to our cardiac flow that I'm used to see all the time. So one of the things with this is, okay, we see that the bladder kind of funnels. We see that there is different factors and different parameters that can be measured here. But one of the most important ones that I would like to have is how can we look for synchrony, or how can we look for coordination of the bladder wall to try to void, right? And that would be separating the bladder wall in different regions, right? So we have the base, we have the dome, we have anterior, posterior, and we have left to right. And in that way, we can see that during the voiding cycle, the dome displaces down drastically, and then the base of the bladder funnels down for a little bit, and then it stays, and then it goes back to pretty much the same location where it was, right? So that's something that I would like to see how much that adds, and especially in different conditions, which could be more characteristics of could have more characteristics of lack of synchrony and stuff like that. So here's, I mean, again, I was until the last minute trying to process this data, and this is one subject, but it's pretty encouraging. If you try to put in the same timeline how the flow goes with respect to the change in the different regions of the bladder, then you see that the flow starts to go much faster once the base of the bladder has funneled, right? So the bladder goes down, and then it's kind of in the same location, but once the changes in the base allow the flow to go, it's pretty analogous to like getting the systolic pressure to be enough to open the aortic valve and let go, right? So at that point is when we see that the flow is going much faster, the dome is just rapidly going down like a plunger, and then we have a more kind of regular position for the base, right? So this is just the start of looking at all these metrics that we can derive from this non-invasive imaging techniques. And for that reason, we need to make sure that we validate all these techniques. I mean, even though these techniques have been validated for other territories, one of the main things that we do in my lab is to use optical imaging to validate the different imaging techniques that we do with MRI. And for that reason, what we've done is we have generated a fake bladder based on a patient data set. We have taken pictures with high-speed camera to track how the motion of that bladder is while emptying. And we have done that same thing with MRI to be able to characterize the deformation of that rubber bladder and get the quantification of the difference of the two. Obviously, there's much more work to be done. We want to create a transparent model that allows us to see what's happening in the regions of interest, mostly for vorticity and all that stuff. But for now, we are concentrating on the deformation of the wall. One thing that I was going to mention that I forgot is, based on this, you can see that you can detect, hopefully, I mean, is good enough, the resolution. Again, these are techniques that we're trying to fine tune for this application, and the resolution might not be the best, but it's pretty good for what we want and allows us to quantify. But if you see at the beginning of the voiding cycle, the bladder wall is pretty uniform, right? And I mean, you see almost no thickness on it, right? But as you advance, then the bladder wall starts to thicken on the anterior and posterior walls, but the dome's still pretty thin compared to the other two walls, right? So it's kind of pulling from the sides, trying to bring it down. The interesting thing is at the end of the voiding cycle, you get pretty uniform, thick bladder wall, which, I mean, we would need to keep studying and seeing more patients, because this was a patient that, I mean, this is a 29-year-old normal subject that we scanned, but as we see patients, we'll see that the post-void residual is going to be higher, and we might not be able to see this clear thickening of a bladder wall during voiding. Why is this important? Because another aspect that we would like to bring into this, and we've been doing, is how does the perfusion change depending on what the condition is of the subject? And if we were able to, so as you see here, sorry that I'm kind of jumping back and forth, but we've been finding that we needed to inject contrast to the subject before doing the voiding scan to increase the contrast between the urine and the bladder wall. So since we have a contrast enhanced protocol, we needed to inject about 30% of the dose before the scan started. And then once the subject has voided, we inject the 70% remaining, because we want to track how is the bladder wall taking that contrast as a marker of perfusion. So once we get a map of regionalized perfusion, we could correlate that to the kinetic analysis that we have and make sure that we can make the analogy of how does the hypokinetic areas of the bladder affect the voiding cycle. So that's kind of the idea of how to couple this. And the way we're doing this is we're injecting the contrast now right after voiding, where we think the bladder muscle is relaxing and taking more blood and being a better marker of perfusion at that time. So with this, I know I went a little bit fast, but I would like to spend time discussing with you guys, if possible. We have been implementing a non-invasive MRI computational fluid dynamics protocol to get into a multifactorial analysis of the whole coupling of the urethra, bladder, prostate, and be able to fully characterize how the biomechanics of the bladder works, not only in BPH, but being able to apply this to different benign conditions in the urological world. We can characterize bladder and prostate anatomy, regional bladder wall displacement, as was shown, and not only with the models, but also with the real-time three-dimensional data. The urinary flow dynamics, I mean, the markers is something that we really want to emphasize, is how quantitative this technique could become and how useful this could become for all the urologists working with this data. And the bladder wall perfusion, again, is something that we are trying to couple with all these dynamics to be able to see how we can get to a better tool in general. So the early results that we have shown, that we have acquired, are very encouraging. They're showing asymmetric contraction in the BPH LOTS patients. We hypothesize that this might be impairing the voiding function. And again, at the end of the day, in those specific population, our goal is to really differentiate what the role is of bladder dysfunction or prostate enlargement when you go towards the symptom generation. So is it the bladder that is not going to be able to cope up with the increased resistance, or is it just the prostate that is obstructing and there is a need for surgery? So with this, I would like to really thank Dr. Bushman, Dr. Shane Wells, Diego Hernando, who have been instrumental in putting this together. Cody Johnson is my student working on this, so that's why he's out of emphasis besides the other students in my lab. My mentors in the K program, Will Rickey, Dale Bjorling, Dr. Bushman, Scott Reeder, and Daryl Thalen. and the funding that has made this possible from the K program and O'Brien Center. And with this, I'd like to receive questions, and thank you very much for your attention.
Thank you very much, Alejandro. That was a really, really interesting talk. So yeah, we're open to discussion. If anybody has any questions, go ahead and just talk. Or if you feel nervous, you can go ahead, you can put it in the chat box and I can read the question.
Hi, Alejo. This is Joe Wang. I really enjoyed your talk, although I think my understanding is not as deep as I could because I don't have much background in the imaging stuff. I think I have a question for you. You may not have had a chance to do that. Do you expect that the BPH patients after simple prostatectomy or the surgery, they'll change the pattern, when they're voiding? Because you said one thing that is highly asymmetric, the voiding pattern. And whereas in the normal, those are young men, I presume, they are symmetric. And do you think the simple prostatectomy will correct that, or this is a thing that already patterned like epigenetically during the disease progression in the bladder?
So that's a great question, and I mean, this is something that is that we have been thinking about. That was actually specific aim 3 in an R01, because we would like to look at what the effect of that is, and that would really answer the question specifically in those patients. How much is it that the bladder cannot compensate for the increased resistance? And how much is it that the bladder was just, I mean, that let's put it this way, if the bladder gets back to a more symmetric contraction, that means that is not fighting the resistance anymore, and that is more prone to we can blame the prostatic enlargement for the symptoms. If the bladder doesn't go back to, or doesn't get to, a normal voiding pattern, that means that the problem wasn't necessarily the enlargement. It was that the bladder was not designed to compensate for those changes, and that's the way in which we've looked at that. But we have not been able to do pre-post surgery, but that's something that we need to do in order to understand if our hypothesis of differentiating the voiding performance from the different angles of the bladder would add to the surgical planning.
One of the key issue is that whether BPH is, what percentage is a problem of prostate, what percentage is a problem of bladder. But based on what I heard, I'm not a urologist, but Dr. Bushman is a urologist, he'll know everything. The simple prostatectomy seems to work on most of the patients, and it have effect. Would that argue that at least to a certain extent is a disease of the prostate? At least it's a key player, not necessarily the whole player, but I think it does play an important role. So maybe I saw Wade is
I'm here. We actually just had a paper published that shows that in 2/3 of our surgical cohort undergoing TURP or open simple prostatectomy for BPH LUTS, the major issue is impaired contractility. And so that actually was a major factor in focusing on contractile function of the bladder in Alejandro's work. And, everyone assumed that the bladder filled like a sphere and contracted like a sphere uniformly, and a loss of contractility was related to impaired smooth muscle function, or some global change in the bladder. And Alejandro's work showed that the bladder does not contract like a sphere. It pulls down on the sides like a plunger, and that men with BPH LUTS can have asymmetric contraction in the bladder. So you get poor coordination or asymmetry, and dyskinesis in certain areas may be the cause of impaired contractility. Now, the relief of obstruction symptomatically is really a complex issue. You ask, how does prostatectomy work with men with impaired contractility? The answer is yes, and that's why we do it. But it also seems that the outlet resistance maintains detrusor contractility. And for men who have really poor contractility, the clinical data that's out there suggests that you get a temporary improvement with prostatectomy, but then you end up getting long-term decompensation, possibly because of the loss of outlet resistance keeping the bladder going. So it's a complex issue and interesting. And the advantage to what Alejandro is doing compared to multi-channel urodynamics is the standard urodynamics only tells you pressure and flow. It doesn't tell you anything about what the bladder is actually doing. And his work can actually show you. The other thing is that we have never really known where in the prostatic urethra the obstruction is. Whether it's the bladder neck, whether it's mid-prostatic urethra, whether it's the apical portion of the prostate, and it may be different in different patients. And his work will allow that to be determined.
Well, congratulations, Alejandro.
Thank you.
You guys are teams.
Thanks, Wade, for saving me there. So I see a question here from Pradeep. So the question is, are you evaluating bladder perfusion during storage phase or during voiding phase? We are doing it. So we cannot do it during the voiding phase because we only have one chance to get the patient to void, and we have to use it to get the pictures of the urine, not the bladder wall, or not the contrast coming in. So what we do is we let the subject void, and immediately after we inject the contrast and we track it going in. So hopefully that answers your question. And then the other one, are you seeing any perfusion differences between bladder mucosa and muscle during storage phase? We will only be able to get the total bladder wall perfusion, which we assume is mostly detrusor muscle, mainly because the resolution of the imaging we have based on, since we're using 3D, we don't have the best resolution. I mean, we have the best resolution possible, but it's not optimal to differentiate different layers of the bladder wall. So we take it as a whole, and then we quantify perfusion based on the arrival of contrast to the wall. So hopefully that answers the question.
Thank you. Nice work, Alejandro.
Thank you, Pradeep.
Hi, I have a quick question. This is Julia Lane. I'm a urology fellow out at Michigan. This is really great work, and especially for me, I think a lot about how the bladder works, especially in people who have dysfunctional bladder. One question I had, just so I'm understanding this correctly, the displacement you're measuring, you're saying the displacement is really not due to the dome contracting, it's due to the loss of volume due to the sides contracting? Or like, that's what I understood from like the last diagrams.
Yeah, we don't, so no, we are, so that's a great point. We are at this point, we don't know what's, I mean, we are thinking that, I mean, we know that the base funnels down and we see that displacement. So our displacement calculations are based on the center of mass of the last point or the last volume. So then we get how much does the bladder deviate from the initial point down to another point. So that's the only way we're tracking. We don't know what's active or what is not active. One thing that I have to say though is one subject that I didn't include here that we scanned back in November had something very interesting. We tried like 5 times for that subject to void, and he couldn't, and he was a 33-year-old normal. At the end, he could void, and he didn't void completely, right? And one thing we saw was that the contraction was from every corner, trying to fight each wall was fighting the other one, trying to void, right? And so that's something that really motivated us to keep looking at this and why the 3-dimensional aspect, or 4-dimensional, because it's time and 3 dimensions. How does it give us more information? So one thing is seeing the thickening at the end of the dome makes me think that everything is kind of pulled from the sides and going down, and then it thickens at the end to get like the atrial kick, for example. It's going to take me a while to stop talking about the heart in my talks, but something like the atrial kick when you get the final part of the feeling of the ventricle, right? So something like that.
I mean, that certainly matches what we feel about how the bladder is innervated, sort of around the trigone and up the sides. The other question I had is, can the MRI discriminate between Valsalva voiding and a detrusor contraction? You know, and urodynamics, where you have the rectal pressure probe that sort of helps us figure out Valsalva versus detrusor. And I don't know, would you be able to see that, or do you see different patterns in how the bladder empties in Valsalva voiding?
That is a great point, and I think we could, because the motion that we're detecting. I mean, I have detected Valsalva several times in these subjects that can't do it, that they're trying to push and like contracting their muscles. We have a resolution of about 1.5 seconds, which is not like the highest resolution, but enough to detect the motion of everything around the bladder. So we would be able to see how much is it outside pressure versus how much is it the bladder just doing it on its own.
Yeah, this is very interesting, and I'm looking forward to see, you know, where this goes and how we can use it clinically.
Thank you. Yeah, that's the goal. Any more questions?
I just have a comment that's not specific to this work, but it just shows how often in medicine we make assumptions that never get challenged. You know, the bladder spherical contracts like a sphere, and that's very, very typical of clinical medicine. And one of the challenges for people who do basic or translational research is they often premise their research on an assumption or a long-held belief that may not actually be valid. And so, you know, people have been studying bladder loss of contractility for a long time, but never actually thought about asynchrony or loss of coordination. And that specific example, I think, is very instructive about many things in medicine where we think we know, but when you drill down, it's just based on opinion or one example. So I think that's a good takeaway message.
All right, so there's no more questions. I just want to thank everybody for joining us today. And you have not put your name on the Google Doc, please do. I saw there's only 22 people on there right now, and we have more participants than that. So please do put your name on the Google document for us. And I just want to do a plug for our next seminar next month on July 8th. We will have Dr. Casey Stedman from Duke University, who will be discussing kilohertz frequency and spinal cord stimulation for restoration of bladder function after spinal cord injury. So regenerative medicine is a super cool, fun topic. And so please do join us for her seminar next month. And I hope you guys have a really great evening. And again, thank you for joining us.
Thank you very much, everybody.
Thank you, Alejandro. Really great talk and discussion.
Thank you. Bye-bye.